As you guys know, because of your integrated work, which is so important for our specialty, may I add, that we have to start thinking of skin disease as whole body disease. And this just fits right in.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, how you doing? I've been thinking a lot about psoriasis recently. What about you?
Oh my gosh, it doesn't stop, does it? I mean, it's one of our prototypical diseases. That's the one that really, I think, got me interested initially in dermatology. I was volunteering at Mount Sinai doing clinical trials as an undergraduate. I still remember, I think I was part of the team that drew syringes for biologic studies. This was real syringes way back when.
Oh man, Hadar, it was in your blood. But speaking of in your blood, that means we got to think big with psoriasis, right? We got to think holistic.
Exactly. And, I think biologics have been a real blessing to help a lot of folks with psoriasis and other diseases. And now we want to be more holistic in our approach, really try to get and maximize all the interventions we can do for our patients. So I think we want to talk today about psoriasis from a broad point of view, from a whole patient point of view. And for that, we wanted to have an expert with us. Shall we introduce him?
Oh boy, do we have an expert. I really consider him a Renaissance dermatologist. I really do think he's a Renaissance man in many ways. We have Dr. Ted Lain. He's a board-certified dermatologist. He's Chief Medical Officer of Sonova Dermatology. He's also an executive director for a group of clinical research sites in Texas and Louisiana. So clearly he does clinic, he does research, but that's not enough because he is so passionate that he also co-founded and co-directs the Science of Skincare Summit. And that's a pretty big educational conference that's really focused on skincare for aesthetic and medical purposes. And not only that, he has a podcast, and the podcast is the Skincare Confidential. But to not make you confidential any longer with us, Ted, welcome to the podcast.
Oh, you guys, I'm so happy to be here. Thank you for inviting me. And my goodness, you guys are so smooth. I've got a long way to go with my podcast intros, let me tell you.
Yes, this is really, I think Raja and I have been mastering the art of introductions, but I think we're still trying to find that sweet spot. We'll get there one day. Maybe at the end of this podcast, we'll see. But today we want to focus really on psoriasis. And I guess maybe we should talk about your journey to psoriasis for a minute, because it's a disease that a lot of dermatologists know and may regard it as almost trivial, may I say, to our specialty. What made you interested? What could be new in psoriasis?
Well, as you know, psoriasis continues to be one of the top researched inflammatory diseases that we deal with. I mean, I started conducting clinical trials in the early teens, so 2011, 2012. And I can't tell you how many trials I've done related to biologics and now small molecules and even peptides for psoriasis. So my interest was born out of all the clinical trial work that we do. And as you know, when you're starting a clinical trial as a principal investigator, you really have to understand the mechanism of action of the new molecule. If it's a new antibody, if it's small molecule, whatever it is, you have to understand it so that you can understand the possible adverse events as well as explain things to your patients or your subjects in the trial. I take that very seriously. So all of it came from clinical trial work. In addition, when I was in training, we had Enroll. Raptiva was getting the bad rap, and of course it's off the market. And it was mainly Enroll and then Humira. So I really started as a kind of embryonic dermatologist during the early biologic days, and then, became a fetus dermatologist, and then a very young dermatologist when we started getting Stelara. If we could just continue that metaphor. So
still young, Ted. You're still young, my friend.
Oh, yeah. I love it. Thanks, Raja.
Yeah, exactly. You took the word out of my mouth. Absolutely.
Yeah, so that's where it came from. And it just, when you start thinking of the whole body connection with the skin, I'll think a lot about that because of the skincare work I do. And again, from clinical trials and acne and rosacea, I put together a lecture on the gut-skin relationship for rosacea. And it's just absolutely true. As you guys know, because of your integrated work, which is so important for our specialty, may I add, that we have to start thinking of skin disease as whole body disease. And this just fits right in.
Ted, thanks for mentioning that. I think the integrative approach really isn't something special, right? At the end of the day, like as physicians, I really hope this is the way we're going. And psoriasis, I feel like, is one of those classic diseases where we have to think beyond the skin. So maybe we can start there. And can you just talk us through what are some of the comorbidities that cross your mind that go way beyond the skin? Because obviously we know there's the skin issues, but there's much more for psoriasis.
Oh gosh, Roger, it's such a good question. I think for those who treat psoriasis out there, you have to understand that about 4 in 10 psoriatic patients have metabolic syndrome and or they have psoriatic arthritis. So to think that a comorbidity is something that is rare in our psoriatic patients is absolutely incorrect. And the problem isn't the incidence. The issue is our questioning our patients about these issues, right? So let's start with psoriatic arthritis, okay? How do we diagnose psoriatic arthritis? We're not rheumatologists, but we all know, I can imagine in most of your communities are much like mine. I practice in Austin. Getting in with a rheumatologist takes at least 3 to 6 months as a new patient. And so we have to start acting as the primary care rheumatology provider for our patients. And we have to start pressing on joints, right? We have to start using screening tools. And guys, it's not hard to learn how to do a joint exam. You can look it up on YouTube and you can see it's pressing at the insertion of tendons, looking for enthesitis. It's questioning, it's looking, comparing. Luckily, we can do side-to-side comparisons there. Everybody is a split body comparison, right? So you really can quite easily start looking and feeling and determining whether a patient is suffering from joint disease. And quite frankly, unfortunately, patients can become poor historians, not because they don't want to get better. It's just that when they live with joint pain for so long, they don't even realize they're in pain anymore. We deal with this. I'm sure you guys deal with this. True. Yeah. And when you do clinical trial work for itching diseases, for pruritic conditions, for prurigo nodularis, for example, and they have to meet a certain criteria to be included in the trial, when you ask them 0 to 10, 10 being the worst itch you've ever had, what's your daily maximum itch? You get somebody with 100 prurigo nodules and they'll invariably put 5.
That is
right?
true.
Because it's like this normalization effect, right? To them,
Exactly.
They're like, oh, this is kind of my life.
Yeah.
And it's hard to accept that my life is at a 10 out of 10.
Ted, I totally agree with you. And I want to jump in. And to me, I've noticed this in HS, for example. People come in, they've suffered all their life, and they'll tell you the disease in the axilla. And I insist first visit, I look everywhere. And invariably, they have like a nodule there, another time they're like, doc, it doesn't really matter. And of course it matters. And because they've been living with this such a long time, they forget. And to me, that brought in the whole concept of true consent, because I think my argument is that people who live with chronic disease for 5, 10 years, since they're teenagers, for example, right, in many of our diseases, they don't even know what life is without the disease. And so I tell them a lot of times, like, I know you're worried about this treatment. Try it for 6 months, come back, and then we'll talk, because then you can give me a real informed consent. Once I cleared your skin, if you tell me then that you want to go back, I honor this. But right now, that's why I allow myself to be a little more aggressive and say, this is the true informed consent. Live without the disease. See what you've been missing. It's like you can't see, and all of a sudden you put these new glasses. So I think this is kind of the power that we have right now to really try to get true consent. So I had to jump there because I think it was a great opportunity for this. And I encourage other practitioners to really think about this. What is the real consent we're getting from our patients?
I also want to float back to what you said, Ted. You're talking about screening for psoriasis. Can you just give us a quick run through on, do you use any screening tools, and maybe what are some key things you ask in the history? Because I think you're absolutely right. We don't get access to rheumatologists. Sometimes I see celebrities before I see rheumatologists in my area. And I do think that, getting that access is so important, and at least us being able to give them access to someone that can evaluate their joints. So how do you approach it? What are some of the questions you ask? What screening tools do you use? Tell us your pearls there.
I'm giggling because in my area, rheumatologists and neurologists are like celebrities. Like you see one and you want to get their autograph because they're so rare.
Seriously. I also want their autograph because I want to know where their address is.
Yeah. Can I get your cell phone number too, please?
Yeah, exactly.
So in terms of psoriatic arthritis, right, I always ask about AM joint pain or joint stiffness, because that usually in a very broad way differentiates inflammatory arthritis versus degenerative arthritis, which, as we know, is a little bit worse at night. Okay. So that's kind of the first question I ask. And then we start talking about, asymmetrical monoarticular joint swelling, usually of the small joints, just the typical questions that you think about with psoriatic arthritis. But honestly, that usually kind of doesn't get me very far. And so I've started to use this screening tool called the Psoriasis Epidemiology Screening Tool, or PEST, P-E-S-T. And it's available on psoriasis.org, psoriasis.org. You can just search for the PEST tool. And it's so simple, guys. It asks a few questions like, have you ever had a swollen joint? Has your doctor ever told you have arthritis? Do you have pain in your heel, finger or toe that is completely swollen or painful? And then it shows the entire body with different joints that they kind of tick off as to where they've had some joint pain. It starts putting them in the mindset of really thinking internally about their joints. And, you get a certain number of questions that are, higher. The higher the number of checks, the more likely they have psoriatic arthritis. And so you get the idea. So the PEST tool is something that I have incorporated in my practice. We just put it into our EMR, and it's something that I think anybody could. There's nothing special about me doing it. Anybody could do it. And it has helped a lot in determining whether patients do indeed have psoriatic arthritis in my clinical view.
I think one of the benefits we have now with really effective treatments for psoriasis, you put a patient usually on a biologic and they clear, and then they come 6 months later, a year later, and you're like, well, what should we talk about, right? And I think that really opens up the opportunity to talk about other comorbidities like cardiovascular disease and mental health disease. Do you find opportunities to do that in your practice?
Absolutely. So one of the other issues with our psoriatic patients is that, let's just talk about metabolic disease because I brought that up
Yes,
earlier,
let's
right?
talk about that. Yes.
So, and you guys are so in tune with metabolic disease as well because of the work you do, right? So metabolic disease increases the risk of, high triglycerides, high LDL, elevated risk of diabetes with insulin resistance, all of that. And it's absolutely, the risk is increased in patients with psoriasis, 34% of patients with psoriasis just about. And then, of course, if their BMI is the higher the BMI, the higher the increased risk of metabolic syndrome as well. So this is something where checking the right labs, making sure you're checking fasting labs, making sure that you are checking hemoglobin A1C along with the fasting glucose, for example, starting to think a little bit outside of your box of my biologic lab work, just to start them on the biologic is important because you can start catching other things. It's like, you see somebody with alopecia areata, you start checking for thyroid disease, same idea, because it's a comorbidity. And so that's what we're trying to kind of achieve with the idea of you've got to start thinking outside of the skin because psoriasis is a systemic inflammatory condition.
Ted, I really want to ask you what you do with these findings when they're positive, both the PEST you mentioned and some other testing. But before I do that, can you maybe discuss, and maybe it's just me, can you discuss the effect this has on your relationship with your patients? Because I think a lot of our patients are really used to the concept of, okay, I'm coming to the skin doctor. We're just going to talk about my skin. And when I start talking to a patient about their nutritional status, about other things outside of their skin, they almost seem shocked.
Right.
Did you have that experience? And what do you think this does to your patient-doctor relationship?
Well, Hadar, I'm sure you can relate to this. I think it absolutely enhances it. It increases the trust level. It probably increases the respect level as well in terms of what we are trying to do for their overall health. And it elevates our stature in their mind. The Seinfeld skit about, what are dermatologists? Why are they needed? Oh, yeah, skin cancer. That's all we're really thought of, right?
Right.
And indeed, we can do much more because the skin is the entrance to the entire body. It reflects what's going on inside. And so I think we just need to be more aware of that and more willing to, first of all, diagnose, but then also to start treatment, Hadar. I think that I feel very comfortable starting metformin, for example, if I need to, if I see some insulin resistance, some slightly elevated glucose, elevated hemoglobin A1C, start the discussion about diet and exercise with elevated LDL and low HDL. Change in diet is something that I've started to talk about more and more, aligned with, the integrated approach, although I've not done your amazing educational activities. It's just something that I've worked on my own. I definitely have started to act beyond my scope a little bit, but I feel comfortable in what I'm doing as well in order to improve the health of the patients with psoriasis.
I always wondered about that, Ted. I mean, I think it's nice that you're taking these steps because otherwise there's just a big delay. And I think we as derms know that there's a metabolic issue. Now, what I've started doing is that I've started realizing it's not glucose isn't the full story. It's the insulin because glucose, you could have a controlled glucose while the insulin is really going up. And so I've started measuring these insulin resistance patterns just because fatty liver is so common in psoriasis.
Yes.
And that can actually lead to insulin resistance. And so I'm now measuring a fasting insulin and fasting glucose, and it's been eye-opening how many people are also struggling with early insulin resistance. So I, like you, have started to realize we need to make some extra tests that maybe I wasn't taught in residency, but it's still, part of the package, and we still got to focus on it and then get them to, who can take care of them.
Yeah, I mean, I'm so glad you mentioned non-alcoholic fatty liver disease. You've got that, which is not inflammatory, and then you've got hepatitis, which is inflammatory, right? And so if it's not inflammatory, you're not going to see an elevation in the LFT. So how do you catch it at all before it gets to the point where it is causing a problem with the LFTs? It's a major issue. And so any ability that we have to try and catch something that could be related to that is important. So I love this idea of measuring insulin. I'm going to start doing that.
Yeah, I measure the insulin and I calculate the HOMA IR. And then I also calculate something known as the QUICKI. And so there are two measures. And I've started to see people that, like you're saying, before they have hepatitis, how do you start, and by the way, our research unit got a fiber scan. We actually ponied up the funds to get a fiber scan. Now we're going to start measuring fatty liver directly in a bunch of these folks just to quantify, God, how many of them are walking around with fatty liver? Did you know that almost 40% of the general population to 50% has fatty liver?
I'm not surprised.
That is just, this diet thing is such a big deal.
Right.
So maybe that leads to the next question. Do you talk about diet, or do you make any mention about diet? And how do you do that, or who do you refer to?
I do it at a very high level. I talk about a plant-based diet, Raja, just because I truly believe that is the healthiest diet. And so we discuss the conversion to a plant-based diet. Of course, for those who are obese with glucose intolerance, now with the GLP-1 agonists that we have available, especially the compounded GLP-1 agonists, which make it much less expensive. It's so difficult to get those approved, at least in my area, that I've really turned to the compounding pharmacies for those to help control body weight as well as the insulin resistance. That along with diet and exercise, it's all part of the healthy lifestyle. You can't just rely on one. It's, as we were talking about earlier, it's all three so important.
That's really true. And then maybe that brings us to the other major thing is mental health and mental state of mind. So can you talk about how do you approach that? Are there screening tools that you use there? I think we touched upon a couple of them right before the podcast. So if you don't mind mentioning the ones that you do use, how do you go about that?
Yeah. So, I think a lot of doctors, dermatology clinicians are probably hesitant to talk about mental health, but it is something that, first of all, we know it's something that we have to talk about with starting patients on Accutane for the iPledge requirements. We have other drugs in psoriasis who have a black box warning related to the increase in suicidal thoughts, suicidal ideation and behavior, at least maybe not a causation, but possible correlation. So this is something where in dermatology, this is something that we need to start talking about. We need to start feeling a little bit more comfortable with it. We know patients with psoriasis both have an increased risk of major depressive disorder as well as an increased risk of suicidal ideation and behavior just at baseline. So I definitely talk about this. I think there are a couple of screening tools if you'd like to incorporate those into your clinical practice. One is, both of these I borrowed from clinical research. It's the HADS scale, the Hospital Anxiety and Depression Scale, HADS, again, available online very easily. I think it's 14 questions, 7 for anxiety, 7 for depression, something like that. And it gives you a baseline score of where they are. And it's something that you can follow over time. It's a validated scale for the presence of anxiety and depression. The other one is the Columbia Suicide Severity Scale, the CSSRS, again, available online, free to use. There's training available as well on how to implement the scale, free online. And that allows you to understand whether the patient is experiencing suicidal thoughts, even suicidal behavior, which could lead you to a quick referral if necessary. So I think both of those scales are also very useful for psoriatic patients, to quickly use them both at baseline when you first start seeing them and start the treatment, and then to follow them afterwards.
This is awesome, Ted. I mean, just going through all of these approaches is exactly what we should be doing, I feel like, as clinicians. But I wanted to put it in a practical context. So you have a patient that comes to see you. We don't have umpteen amounts of time in the clinic. We still, have to be reasonably efficient. And a lot of the clinicians out there have to be reasonably efficient. So how do you approach this? What are some of the things that you might touch upon with the patient? How do you decide if they need systemic therapy or not? Are there, a lot of people look at BSA, but I feel like there's more to choosing to go systemic or choosing something beyond topicals. And how do you do it?
Yeah, I mean, honestly, that's how psoriatic arthritis screening tools are helpful, because they do allow you to add that second diagnosis if it is present. If you truly believe that psoriatic arthritis is present, you add that as a second diagnosis, and it does enhance your ability to prescribe that biologic for a patient with relatively limited skin disease. If it's limited to less than 10% BSA, if their PASI doesn't reach 12 or higher, if they don't have it in special sites, scalp, genital, for example, it gives you the ability to kind of add that to the chart, which could help you in getting the right treatment for the patient. Raja, in terms of determining which treatment I'm going to use for which patient, it's difficult. I applaud companies that there's a company out there that has a screening tool, right? It's like a little microneedling device that you push onto a psoriatic plaque and you send it in. It's called Mindera, Mindera. No financial relationship with that company whatsoever. You send that into their lab, and they give you a score essentially based on a genetic analysis of that sample, and it tells you that this patient is most likely going to respond to, I'm making this up, an IL-17 versus an IL-23 versus a TNF alpha. I think those are the three major classes. And so there are some screening tools now starting to be developed that point us in the right direction to figure out which class of drugs our patients are going to respond the best to. Because as we know, you could look at the data from these different clinical trials and you say, hey, that's some amazing data. I'm going to apply that as first line to all my patients, but your patients don't follow the clinical trial textbooks, do they? And so there's genetic variability. There just must be. There's some variability between patients that we just don't understand. And I think anything that we can do to allow us to, with first line drug choice, achieve better results, I'm all for that.
Ted, those are such excellent teaching points and pearls. I think all these screening tests are really, really good and allow us to really kind of go beyond just the usual treatments that we would give. And I think to kind of come back a full circle, I think along this conversation, what I'm realizing is that actually nowadays, being integrated is not really a limitation, and even in managed care, because as we mentioned, well, the first visit you get them better, but then the second, third, fourth, fifth, sixth, seventh, eighth visit, you have a lot to talk about after their skin is clear, and you can bring more value to your patient. They keep coming back, and it doesn't take much time. You increase your reputation. Maybe they'll refer one, so it even makes business sense to do this in a way. But more importantly, it really enhances your relationship with the patient. And you said something about almost like being beyond the scope, and I really think we are doctors. We are trying to bring this full circle where we're not just taking care of the skin. We're taking care of the entire patient who happens to have skin on top of them.
And
with
it's
the
still
disease.
taking care of psoriasis, right? It's still part of it.
Exactly. And that was kind of my point, is how you mentioned that even if body surface area may not be so significant, but the joint disease is significant. The mental illness is significant.
Hadar, can I mention something funny here? I was talking to a rheumatologist once about, hey, how do you guys determine when it's psoriatic arthritis? You know what they told me? And both of you will get a kick out of this. And he was a very well-respected rheumatologist. He said, well, we find their joint pain and everything comes out negative, and then we wait for you to diagnose the psoriasis, and then we call it psoriatic arthritis.
Oh, wow.
So, so it's like we have to work closely together, but at the end of the day, we should be the drivers when it comes to
Right.
psoriatic arthritis.
Yeah, and it's to the point that we are doctors. We have all these amazing tools now in our toolkit. We got good training. We shouldn't be afraid to keep training, as you mentioned. If you're not sure, look it up, ask someone. There are resources online. It's really now, there's almost no excuses now. We will have the time, if not the first visit, the second one. So really, thank you so much, Ted, for taking us through all this and really reinforcing, at least in my mind, that when I care for patients with psoriasis and beyond other skin diseases, that I can really truly be holistic by doing the right screenings, really taking care of their whole body and everything that relates to that, be it psoriasis or even beyond. So thank you for your time and your expertise. I wanted to give you just 1 second, last second kind of opportunity to let people know where they can find you. And I know you have a very successful meeting as well, so feel free to mention that as well.
Oh, Hadar, thank you so much. So I'm on Instagram at Dr. Ted Lain or Edward Ted Lain on LinkedIn. The meeting is called the Science of Skincare Summit, scienceofskincaresummit.com, or the podcast is Skincare Confidential, available just like this podcast on all major podcast hosting sites. Yeah, it's a meeting that really focuses on the science underlying skincare, both medical and aesthetic purposes. And the idea is to give pearls, right? To make sure that the people who attend our meeting, physicians, mid-levels, estheticians, come away with better ideas on how to implement skincare pre and post procedure or alongside medical therapy, so they can understand and utilize all the wonderful science and research that's going on in OTC skincare right now, which is truly impressive.
Well, there you have it. You heard it from Edward. What an official name. Thank you, sir. Thank you for joining us. Thank you for your expertise, and I can't wait to have you back on this program. Thank you.
It is my pleasure, guys. Thank you so much. Congrats on all your success.
And that's a wrap for today's episode. But these conversations are just way too good to end here. Wouldn't you agree, Raja?
Absolutely, Hadar. That's one of the main reasons I get so excited about our conference, the Integrative Dermatology Symposium. Every year, it's a chance for us to continue expanding our minds for what's possible in dermatology for our patients, and also to bring the latest clinical knowledge back to the clinic. And this year's theme has been long awaited. Do you want to spill the beans?
Oh, yes. You don't want to miss this one, folks. This year's theme is Nurturing Skin Resilience, the Science of Aging and Wellness. And it's happening from September 26th to the 29th, 2024.
Yes, and we'll cover topics from conventional medicine to traditional approaches, from inflammaging to exosomes, and from cosmeceuticals to women's health and more.
The agenda lineup looks amazing. Not only the topics, but also the real-world case discussions, workshops, and networking events. No wonder we've expanded the IDS to 4 days. So much more to learn and do.
Plus, you can't go wrong at a brand new resort that just opened up this year at the Lowe's Arlington Hotel and Convention Center in Arlington, Texas.
Texas, here we come! And for our esthetician colleagues, please join us on Sunday for the Integrative Aesthetics track.
So come check out integrativedermatologysymposium.com for all the details. We hope to see you there.